So the next presentation is Focus Wards, Embedding a Voluntary Organisation to Health Service across North Lancashire, the Well Communities, and that's Claire Niebieski from NHS Lancashire South Cumbria Integrated Care Board.
Hello everyone. I feel like Sam and Courtney's presentations have segued us really fantastically into what we're about to talk about. So my name's Claire Niebieski. I'm Head of Population Health for NHS Lancashire and South Cumbria ICB.
I'm Carl Grace. I'm one of the project managers for the Well Communities.
And I'm here to talk to you today about focus wards and what they are. And Carl is going to I'm going to talk at a kind of a zoomed out level, and then Carl's going to talk more specifically about some of the one of the projects within the focus wards work after kind of I've finished my bit. Do I move the slides on myself? Apologies.
Or they can do it for you here.
Yeah. So focus wards. So we're doing a piece of work currently in Lancaster district, and there are 4 specific wards of interest, and they are Poulton Westgate, Skirton West, Harbour, Heysham North and Overton. And what is interesting about these wards is these 6 wards are in the top 20% decile of deprivation. But in addition to that, there are more than 6 deprived wards in Lancaster district, but these 6 specific wards are driving attendance for paediatrics and adults respiratory in emergency department. So as a system across Lancashire and South Cumbria, and I know Sam, you talked about what you talked about, that kind of fits nicely with that, and Courtney, what she's talked about in terms of paediatric admissions really kind of resonates. So you've kind of got all the background and research relating to that. So we're doing a piece of work collectively as a multi-agency partnership across the whole of Lancaster district to really look at how can we work and what can we do together to try and tackle some of this. Just a point to note that these, particularly 5 of the 6 wards, and 1 of them are in what we would call declining coastal communities, where tourism was once kind of it was a really affluent area and lots of tourism, and now what we're left behind with is lots of hotel, bed and breakfast accommodation that have now been turned into houses of multiple occupation. So there's lots of low quality housing. So we've got an already real disadvantaged populations in these 6 focus wards, very vulnerable. Things like rising sea levels, so that's we're losing investment in jobs. However, conversely, the Eden project is going to kind of do the opposite to that. But what we need to be really mindful of when working with Eden project is that actually we don't widen those health inequalities that are already there. I think they've been here today to speak as well. So. Also as well, there are lots of drug and alcohol issues. There's low house values, so anybody who has bought a house in those areas really does find it difficult to leave. Higher levels of poverty, and again, what Sam talked about earlier, there are disproportionate levels of poor health, multiple long-term conditions, lower life expectancy, and lower healthy life expectancy, all within these wards. So this is a Public Health England system map of the causes of health inequalities. So people do not live single issue lives. People do not come into A&E or emergency department with just a respiratory condition and that is it. People have multifactorial lives, and there are a number of things that impact on people's health and well-being. So what we need to do as a system is, when we are working in our localities, we need to get better at joining that up and not really health looking at their bit, which is the health bit. We really do need to join that up and join all of the wider determinant factors up. So what we're actually doing in those 6 focus wards as a system, like I said, we've come together and we're working proactively to actually find people. So what we're doing is we're searching people in those wards through primary care and NHS data, people who haven't been in touch with their GP, because we tend to find that people who do disproportionately access ED don't tend to proactively manage their own health and well-being or access their GP or healthcare appropriately. So we're proactively finding those people through the lens of respiratory and through the lens of paediatrics. What's really important to note here is that is our lens only. It is not the beginning, the middle and the end. It is a lens to find people, and some of the examples of the work that is going on in those wards is once we've found people that haven't been in touch, that have got multiple long-term conditions including respiratory, that do live in one of those 6 focus wards or in particular certain streets, that the primary care will go out and outreach, knock on doors, put community clinics on in those areas. They're also partnering up with Citizens Advice, because what they tend to find when they go out into some of those wards, and Courtney talked a lot about that, Sam did as well, it's multifactorial, not a single issue life. Health and well-being is usually at the bottom of a priority list of some of these people, individuals and families, and presenting factors that they can be met with is things like poverty, chaos in their lives, debt, drugs and alcohol issues, domestic abuse. So it really is about going in as a health professional, but recognising that all these other factors impact on individuals, and they cannot begin to address somebody's health and COPD or respiratory without looking at them as a whole person. And that's some of the work that's happening. Linking it back to the research, one of the key roles within this is a respiratory health and wellbeing coach within these 6 focus wards, and we're doing a research project with UCLAN at the moment that is looking at the respiratory health and wellbeing coaches. We're also looking to recruit research champions out of the workforce who are working within these 6 focus wards, linking back to some of the comments made earlier about research is everybody's business. It's not just PhD and research champions. I'm going to hand over to Carl now, because Carl's got a really good example of work that he is leading and doing across Lancaster district, some of it rooted in some of these wards, but really focusing in on some of those populations that where health actually is not a priority. So I'm going to hand over to Carl.
Thanks. Have you got the slide?
Yeah.
Thanks. As I said before, my name's Carl Grace. I'm one of the project managers for the Well Communities. I'm kind of the one that's absolutely not academic-y, not researchy. So, you know, I know there's a few of us in the room, but I sort of feel a bit alienated by all this stuff. And I thought coming today that it's going to be like boredom, my bitload of boredom. But I was really fascinated by the first presentation that was given today, and how much it relates into what I'm going to be talking about today, and what we actually do within the Well Communities in the hospitals, both in Lancaster and we're in Barrow Hospital as well. You know, so why do I relate so much to this? Because I now see it from 2 sides. I was the service user. I was the familiar face, constantly being admitted into hospital for either overdose, alcohol withdrawals. The chaos of my life was putting me in hospital with the things I was getting up to. And that went on for 32 years of my life. And what I've understood and what I've really got from today is, you know, how much I recognise now that every time I was admitted to hospital, the symptom was being looked at and addressed, but not the cause of what was going on for me. What was being addressed was the overdose, it was the withdrawal seizures, it was anything else, but it wasn't looking at what my problem is. And what I've learned today is my addiction. You know, I don't want to leave anyone guessing, because it brings up lots of questions. Well, what was he doing? What was he up to? You know, I was the crackhead, I was the smackhead, I'm an ex-offender, spent years of my life in and out of prison, and it was all because of my addiction. And that was never being addressed, because the people I was going to just had a job to do. They were underfunded, they were undersourced, they didn't have the knowledge of what I now know about my addiction to help that. So I kept on going into hospital, and very understandably, I was met with frustration, because if I didn't know why I kept doing what I was doing, and if I didn't understand why I kept drinking and why I kept using drugs, knowing the situation it kept putting me in, and I'm quite an intelligent guy, if I couldn't figure it out, and people are saying to me, just stop, and I'm like, oh, I didn't think of that. Because I was being driven by something I didn't understand, and it all roots down in trauma, which is why I found that, we were talking about deprivation and how much deprived areas will create more problems. It's easy to see that deprived areas create more trauma. For me, the trauma you couldn't see, it took me 2 years in recovery working on myself to find out what the trauma was. But where there's more deprivation, there's going to be more trauma. And I identify now with my trauma that, I had to be looked at. It had to be addressed, because otherwise I was going to keep on turning up in A&E. I was going to keep on turning up for the symptom to be addressed, but not the cause of my problem to be addressed. So the work we do now in the hospitals is fantastic, because all of us who go into those hospitals have been the service user. And what we've basically done is we have found a way out. So we then go into that, and the first time we'll see someone who will get referred to us and we'll ask to go and sit by the bedside, because we go bedside with people who are taken into the hospitals. That's where we start. The first time we'll go in, do you want to come and do what we do? Do you want to come and use our services? Do you want to? And no. Second time, no. Third time, you might get a bit of interest. Fourth time, we might get them and they might come and do some work with us, and they might start to actually deal with the underlying problem, which is generally the addiction. Or whatever cause it might be in whatever field you're actually working in the hospital. It doesn't have to be addiction, but it's always the root problem that needs to be looked at. And how does it benefit the actual hospital? We have built up some fantastic relationships with the ED departments that we work in, the discharge departments, the prescribers, the doctors, everyone that works in there. We've built up relationships with them to help educate them from the inside that, they're not doing it by choice. No one chooses to live the life I was living. I was being driven by addiction, and as soon as I dealt with that addiction, then things started to change. If you look at on the chart on the right-hand side, there's a circle, and all the arrows pointing out are all the stuff that we can get people involved in. Because what happened to me during my addiction, and as the addiction carried on and my life carried on the way it was carrying, is I lost a relationship with reality. I didn't deal with reality the way other people do. I ran and I hid. And I generally hid in substances to avoid reality. All of the things that we do is we start to give people a better relationship with reality. We start to introduce social networks. We start to introduce friends who actually care about them and will support them. And we start to, all the things that we do at the Well, which is on the right-hand side, is what we're able to actually deliver and offer these people, getting them involved in some kind of recovery. And the reason it works for us as a lived experience organisation in the third sector, coming into statutory services and the NHS, is because we've been there, we've done it. I'm not going to mention frustrations of being undervalued and frustrations of not being recognised, because that's a whole other day's worth of presentations. But it's just fantastic that we have built these relationships with the NHS in Lancaster and in Barrow, and that we're able to see so many changes in so many different people's lives, because we understand that it's not the symptom that's the problem. The problem with addiction is not the seizure. That's just the result. The problem is the addiction, the reason. Get back to the underlying trauma, find out what's gone on, and then give people places and spaces to actually explore that, work with that with support. So I think that's all I can say about that, what we do. It's an amazing opportunity. It's funded by the ICB. It started in 2019 with a pilot that went live straight away, which took us straight into COVID. So we're trying to set this thing up online. We're trying to have Zoom meetings with people who didn't even want to talk to us in the first place. So you can imagine how well that went down. So it started a bit slowly because of COVID. Just one example, and I've just been with him now because I'm a bit close to our Morecambe branch, to have not been dragged over there for an emergency. That's why I missed lunch. I was with a guy, call him Scott because his name's Scott. 9 times he was referred into Lancaster Royal Infirmary with alcoholic seizures. So 9 times he had to be treated by the same staff that were seeing him coming into ED. They were understandably getting frustrated with the situation. those very same staff now work side by side with Scott, who goes in and sits at the bedside of the people who are the new familiar faces. And they see the work that Scott does with them, and they see what Scott can do once those people let him in, because they've got to let him in for him to be able to do that. And sometimes it takes quite a few visits before they start to let us back in. So I'm going to leave it there. I'm going to hand you back over to Claire.
Thank you, Carl. So just kind of bringing it round full circle. So a lot of the work that Carl does is driven by people who go in through emergency department and then end up being admitted as a patient. And Carl, as an example, will come in and support people with addiction issues. Just to kind of finalise in terms of linking that back to the research, there is a research project underway as well at the moment between the Well and youth that UCLAN are supporting as well around the lived experience and the importance of people with lived experience of drug and alcohol issues in this space, supporting people to recover from trauma and drug and alcohol issues. I think that's it, isn't it? Yeah. I think, and I think it's just really key to really point out that actually it's all getting together in this space. It's not just the Well's responsibility. We all need to work side by side together.
Thank you very much. Oh, I thought you were going to do his turn. No. I was waiting for the... So it's great to hear that link between the emergency hospital entrance. You know, this is the way into specialist care, and this is the way to look at the root cause and the prevention. And I'm hoping that the message that you're beginning to hear, and I would say this as art director, is that the great advantage of the infrastructure that is the ARC is that we're interested in all of that and everything in between, and finding how those different ends of a pathway can collaborate together with a common purpose and a common interest and link up so they can share what we call knowledge mobilization from the different types of people involved in these pathways, involved in these problems and solutions, coming together to come up with novel ways of working and to evaluate them, do research, or put into practice something that's already been shown to work elsewhere and see how we can make it work here, write that up and let other people know to spread it. So that's what hopefully the ARC enables us to do, and why I'm now going to let you rush off for tea and coffee unless there's any questions, so that you can do that networking and have some of those conversations, and then come back at 1:15. So we've got 15 minutes, but I will have time for one or two questions while we have time for that beforehand.
Hi, it's not really a question, but I just wanted to say how good it is to hear that, because I'll never forget my A&E placement as a student nurse in Barrow, and there was somebody came in with an overdose, and I was comforting him. He was crying, and one of the nurses said, "Oh, he's in here every week. Just leave him. He'll be back next week." He brought it on himself, and I just couldn't really believe what I was hearing. And then, so it's really good to know that you guys are going in there and talking to them and educating the staff.
Yeah. So Pooja's going to come in, and while the mic's going across, if any of you are working in organisations that do Schwartz rounds and you've never been, please go, because it addresses these issues around compassion and the emotional impact of our work, and hopefully reduces some of that sort of thing that you were saying you experienced, by enabling people to share their frustration but re-energise in thinking, remembering why it is they're doing that job, and that it is about compassion and care and not about why am I still here. A Schwartz round, come to me in the break.
Hi, just picking up on that point actually, and thank you, great presentation, but just, you know, the work you said that you're doing now when you go back into the wards, do you think that's being taken up by, you know, the staff and the services, kind of the value of that work and it feeding it kind of back into the health system as well?
I haven't got any facts and figures on that, but what I can say is from the staff that we have going in there, there's been a noticeable change in the culture of the staff that are dealing with the familiar faces. And if that's not good enough, then I don't know what is.
Yeah, great. And I mean, just someone who's worked in substance misuse for 30 plus years, the prescription for opiates is the gateway to the long-term support that people need to stop using opiates. All the prescription does is stop people hopefully coming to serious harm whilst they get education, get a job, get somewhere to live, re-engage with their family, re-engage with social support, and able to live happier, more fulfilling lives. So we over-medicalise these problems very often. The solutions don't lie in the prescription. The solutions lie in how the world around them is able to change, and they're able to change within it. That's really where the work happens, and that's why this is so important.
I was just wanted to ask...
Not that that's political in the slightest, I just hasten to add.
I was just going to ask, though, is the vision for this to be expanded? Where do you see it going out of Lancashire? Because obviously, if it's successful and the NHS has got a successful pocket of innovation going on, how does that get shared wider across the patch?
Our CEO is so involved now in driving lived experience forward as a concept and as a body of lived experience, not just for the well. We can only operate where our hubs are. We're in Kendal, Morecambe, Barrow and Carlisle are our hubs. We can only have staff coming out of our hubs. We wouldn't be able to set one of these up remotely. But our CEO goes around the whole country involved in lived experience organisations, showcasing how this stuff can be taken into other areas right across the country. So that's how it's going to spread.